Hi everybody, my name is Luc Rutten. I'm a master dental technician from Belgium and I have a dental laboratory together with my younger brother Patrick. In total, we are 5 people working in the lab. The focus of our daily work is ceramics and in the last couple of years the aesthetic implantology. This means zirconium dioxide and on top veneered with ceramics. Yeah, of course, when I go a little bit into the history, we see that we have, the last couple of years, a tremendous evolution concerning the possibilities. CAD-CAM systems are coming in, new materials, for instance, like zirconium dioxide, which is our favorite material to work with. So I think aesthetics means to me that we have a beautiful aesthetics, a beautiful tooth. It's a theory of beauty, of course. This is the definition of aesthetics. But not only the aesthetics, we have to do more than just aesthetics. We have to deal with function. We have to deal with precision. We have to deal with occlusion and articulation, function, which is very important as well. And all these items combined, this is for me aesthetics. Indeed, so what we try to do is not focus on single front crowns, but I think that the most challenge you can have is a implant restoration on top of 6 or 8 implants in an upper jaw. With a tremendous bone loss, it means that we have to compensate the vertical dimension with pink porcelain, which is very challenging, especially for the phonetics in this case and the hygiene as well, to maintain these kind of restorations in combination with a good phonetics. It's not easy. Sometimes you have to make some compromises. In any case, we prefer fixed restorations, of course. It's more comfortable for the patients. And what we see internationally also, that most of the patients, they're asking for fixed restorations. It's also a psychological matter that they are having a fixed restoration, a removable restoration is not so easy to deal with mentally, I think. That the mental aspect of a removable implant restoration is heavy. I think it's easier for the patient to have a fixed restoration in his mouth. To me, it's definitely a second choice decision, but you have to understand the patient. Sometimes they have most economical reasons that they can't afford ceramics, which is a little bit more expensive compared to acrylic teeth. The disadvantage, of course, of these kind of works, the clinician should inform on beforehand the patient that he will lose a little bit the occlusion after a couple of years and that he will bring the restoration into the lab again to renew with new acrylic teeth. That's a very good question. I think that backward planning is absolutely necessary to make it a success, the restoration. So for a backward planning, it's like constructing a building. When you construct a building without the plan of the architect, there is no building. It goes wrong. It is exactly what we have to do when we have to restore an upper jaw or a lower jaw or both. So we need definitely a plan, and the plan is the backward planning. It means that we already make a setup before we start. The setup in sense of this will be, it looks like the end result already, although we have to do all the technical steps in the lab. It depends on what stage we are in the lab. So when we have produced already or created already abutment, so to speak, and then on top a cementable bridge, this is very difficult to change. When we have to deal with a titanium PIB, for instance, with on top of it acrylic teeth, that's easier to change. So the sooner that we are in the treatment planning of the patient, the better. So we also have Noble Clinician, the program in our lab, and when the oral surgeon or periodontist mails us the file, so we can judge the plan. Is it correct? Sometimes we can say we move a little bit the implant there or there in this direction, that the interocclusion is better. Not only aesthetics, but sometimes the interocclusion might be better when we do some changes in the implant placement. Definitely, it is so important to involve us as soon as possible in the treatment planning of the patient. Of course, as a dental technician, I understand perfectly the limitation of an oral surgeon. There where there is sufficient bone, he can insert some implants. So, but what we don't like is, for instance, that we have to work with cantilevers. Since zirconium dioxide is our material we like to work with, so we don't like to have a big cantilever, at least sometimes a little molar. When we have, when we can avoid it, we will avoid it. So this is what we don't like to see, in fact, and what we don't like to see either. But this is a little bit going into the history of implantology, that in the beginning, where 6 implants from canine to canine were installed, the patients will have phonetical problems and, of course, huge cantilevers. So this is not nowadays work any longer. I think that the problem still exists. So one does not forget that there is also chipping on porcelain fused to metal crowns. So I think that with the new material, zirconium dioxide, we have a difficult start. We had a difficult start because the industry, they brought something on the market without knowing and without informing the dental technicians how to deal with zirconia dioxide. So this was the main problem. Now I think we are more than 10 years later. Many articles has been written. You can find in the literature a number of articles how to deal correctly, how to treat correctly zirconium dioxide. It's a fantastic material, but with limitations.
For more education programs, visit the Guide Institute at www.guidedental.com.